we had a couple of palliative care sessions really around looking at how do we increase access to medications for palliative care and for the entire care continuum, and also looking at how do we ensure that the patient's voice resonates throughout care. And we came up with practical examples around how to sort of use the existing resources, but reprioritize health, for instance. We do have a lot of, and I think it was Dr. Emmanuel Lukira who pretty much sort of said there's a lot of wastage in the health systems, and perhaps really looking critically at how do we repurpose available resources in order to improve the care delivery for our patients. We also looked at the rise of existing technologies, again, with the pandemic, the fact that, again, we're sort of having to move to more telemedicine and telehealth solutions to these, looking at, can we have virtual tumor boards? Can we have virtual online support? And palliative care also be provided through these online models? And how do we then also improve the technologies, such as things like the care delivery systems? And we sort of made the point around technologies are not necessarily just shiny new toys, but even looking at innovations in the health systems. How do we tweak our processes that would ultimately go a long way towards improving palliative care for our patients? And then really sort of ensuring that the patient's voice percolates. And I gave the example of the multidisciplinary breast clinic that we're running at the Aga Khan University Hospital, where we do have the tumor board, but as a next step, we invite the patient and their families to come in and have the discussion around, yes, listen, this is what we think as professionals, but what is the, what are your thoughts and what do you think? And that really trying to encourage the model of shared decision making. And perhaps some people say maybe we're not labor thin on the ground and we may not necessarily have as many of the workforce, which is kind of the big challenge in terms of most of the countries or centers in sub-Saharan Africa, and saying, how do we effectively leverage some of these technologies to ensure that patients' voice is still emerging? And really, I think what resonated with that is the need for structured advocacy. And in relation to that, we had an amazing session around cancer epidemiology, and excellent work by Chemtai Mungo on the use of the feasibility of using thermoablation for cervical cancer or precancerous lesions in patients in women who had HIV in Western Kenya, and looking at really encouraging African oncologists, African scientists to really take ownership around generating context-specific questions, or questions that address pain points for our patients. Because I think for the longest time, we've sort of relied on data from other parts of the world, which is okay. But what I think many of us realize in practicing in Africa is that we're seeing a very different disease pattern. We're seeing our patients are not necessarily having the same demographics, and not necessarily responding as we'd expect to different, therapeutic interventions. And so there's definitely a need to generate more organic content and research from the continent that helps to answer these questions for our patients. And so I think it was very encouraging to sort of see the rise of all these young scientists and African oncologists at the conference, just sharing their knowledge and sharing on all that needs to happen. But we were saying, underscoring this as well, is the need for structured advocacy. We know, for instance, that spending around just funding for health in many countries in Africa is still way below percentages. We're looking at about 4 to 5% for most countries. If you compare it to countries in the West, which is about 11% onwards. So really making the argument around health investment rather than health expenditure, and making economic arguments to policymakers in the language they understand. Sometimes as clinicians or health workers, we tend to be a little more technical and sort of trying to compel or appeal to the aspects of clinical care, but actually making the point and even driving research around this that helps to sort of look at what are the key gaps in our health funding, and changing that argument to really trying to invest in our health systems actually saves the countries or the policymakers, or saves the country considerable amounts considerable amounts of savings. And so the real need for advocacy on that front. And then one of the other areas that we talked about was strategies for screening and early detection. And I think we had an excellent talk by Dr. Frotberg from the WHO, really sort of making the distinction around screening and early detection, and really looking to tease out the need to sort of contextualize a subsequent discussion by members of the excellent panel that we had, was really around framing the narrative of, cutting your coat according to your cloth, but one, really understanding that screening is just one of the aspects of care, and what has been the trend, unfortunately, as that we've had lots of advocacy, but it hasn't been very structured. And so what would happen is there's a lots of awareness and whatever being generated, which is great because it means our patients come in earlier, we're able to downstage tumors, we're able to pick them up earlier, but then it's not enough to say, listen, you have a lump. It's the then what? And so ensuring that the systems are prepared in order to receive these patients who we're saying we're picking up earlier, because unless you ensure that the entire care cascade or entire diagnostic or treatment pathway is solid, then one would argue that sometimes screening might be criminal, because if you're just going to stop there, then it doesn't do anyone any favors anyhow. And so really looking at how do we strengthen the entire system. And then looking at the feasibility of screening programs in the context of the funding that's required, and really the need for early detection as a very central strategy to downstaging tumors. Keep in mind that in many parts of sub-Saharan Africa, actually in most of sub-Saharan Africa, quite a number of our patients are diagnosed with advanced disease, stage 3, stage 4. And so looking at how do we then shift the narrative? For breast, for instance, we're looking at practical measures like really pushing the agenda on breast awareness, clinical breast exams, really sort of demonstrating or resonating that strategies, but making sure that even as we push these strategies, we're like, what is a systems preparedness? We can talk about clinical breast exam, but how equipped are our healthcare providers to do a good clinical breast exam? What is the knowledge that the health workers are able to impart? Because ideally your primary healthcare providers, your health, your clinical, your community health workers should be the first line. And so strengthening and empowering them to have the tools around the basic signs and symptoms of cancers, and really trying to avoid operating in silos, because again, we were sort of sharing and having stories around women who may be coming in for a different clinic, and so for instance coming in for their HIV care every month and then getting diagnosed with a stage 4 cancer. That is a system failure that is on us. And so how do we sort of get our healthcare workers to look at the patient in totality, and rather than sort of try and optimize the narrative around, reframe the narrative around chronic disease? Because if a patient is coming in, for instance, for their the patients coming in for their hypertension or any chronic illness, or even for their family planning needs, that's an opportunity to leverage to have the discussion around, screening for breast, screening for cervical, and so, or any other cancers. But it's a time to actually really think critically about integrating the approach to patients and really making it patient-centric, I think was the common theme in all of these talks and discussions.